This is Chapter 25, The Child with Cancer. So for diagnosing cancer, we're going to be doing a lot of testing. Lab tests, so think about the least painful, least frightening way to draw blood from a child. LPs, which is a lumbar puncture. They'll use imaging to see the tumor or whatever they're looking for. They can do CT scans, MRIs, PET scans. And then they really need to get a biopsy, which means taking a little sample of the tissue that they're worried about. So here's a picture of what a lumbar puncture is. They're going way down here, like between L3 and L4, and puncturing below the tip of the spinal cord. So you can reassure parents there's no way of, injuring the spinal cord, but they're going into this area that's filled with cerebrospinal fluid. So typically we have the child laying down with their back curved to try and spread those vertebrae out as much as possible, and then the physician will feel for the space, and our job is to hand them the sterile things as they are doing it and collecting the CSF fluid. And once they puncture into that lumbar space there, this will be dripping out the CSF fluid. Another thing we do are scans, such as CT scans. And again, think about what will help a child to be less frightened. They have to lay still as they go into this. The important thing is them being still. And that teddy bear is not really going to cause a problem. It's not radio opaque. It's probably not going to show up. And especially if they're doing his head, it doesn't matter if it's down on his tummy. So think about what they can have that won't interfere with the scan but will make the child more comfortable. And then treatments. So the main treatments is, if this is something with a tumor, we're going to do surgery to get that tumor out. If it's something solid where we need to do a biopsy, they can often do that. Take the tumor out and then send it to pathology to diagnose it. Sometimes they have to do the biopsy first, just by putting a needle in and taking a piece to see what they're dealing with. Chemotherapy, this is probably our most common thing, is to use medication, chemotherapy agents. This does take some special training. Not every nurse can do chemotherapy. You've got to be hired by your facility and then specially trained. Most of our medications for kids we do weight-based. Chemotherapy is different. Most of those they do body surface area based. So they're doing math on every medication for every child, and it takes 2 people to check it and make sure it's right, because these have really bad side effects. You don't want to give an overdose. And if it's one of the medication that does potentially have an anaphylactic reaction to it, the recommendation or the expectation is that we observe that child for an hour after we've given them that chemotherapy. Sometimes chemotherapy is before surgery to shrink a tumor, either to relieve whatever it's pushing against or just to make it easier to remove it surgically. And sometimes it will be after surgery in case it was not encapsulated and they feel like there's some little pieces of the tumor still in there, or if they think it may have metastasized or seeds have spread that could develop into other tumors. Then we're going to do chemotherapy. Radiotherapy, this is irradiating. So this is often done with surgery and or chemo, and it can be to reduce the size of the tumor. Occasionally it's to destroy the blood supply to the tumor, so the tumor can't grow, because tumors take a lot of blood. And then kind of our final treatment that we'll do on certain cancers is a bone marrow transplant, and we'll talk about that a little later. So these kids who are getting chemotherapy need some sort of a central line. You can't give these drugs into peripheral vein. You'll do too much damage. So here's a little girl with a Mediport, and hers is accessed. right now there's a needle through the skin into the Mediport. These are different types of Mediports. This part is under the skin, and when it's not in use, all you have is a little bump. This is underneath it, surgically implanted under the skin. And then when you do need to access it, we'll put Emla cream over the skin to numb it and poke right into the center. This one has 2 separate ports, and then these other ones are just different brands with 1 port. So the center part is rubber, and that's where the needle goes. And then once it's been accessed and the needle is in, we're going to treat it like any of our other central lines and keep it covered with the Tegaderm. We use those little bio patches, the little blue antimicrobial patches. So there are some emergencies that can happen when we're treating a child for cancer. One is tumor lysis syndrome. When we kill so many cells all at once, the breakdown of those cells can cause metabolic abnormalities. We can have an emergency situation where we've thrown that child's either electrolytes or acid-base balance out of whack. Hyperleukocytosis. Sometimes the WBC count will go up so high that it becomes dangerous. All those WBCs, you shouldn't have that many in your blood, right? These are a huge cell, and when you have too many of them, they can clump together in your capillaries and plug your capillaries, which means blood is not getting past that obstruction. So the tissue beyond that capillary becomes ischemic, and ischemic tissue is very painful, and if things are ischemic long enough, then you can get necrotic, which is dead tissue. Superior vena cava syndrome, if you have a tumor in the chest that's pressing on vital organs or circulatory, interfering with circulation. And then spinal cord compression. A lot of the cancers have a tendency to invade the central nervous system, and so then you get the cancer cells in your CSF fluid, and this can cause severe back pain. So signs and symptoms of cancer. Well, certainly an unusual mass or swelling, paleness. Tumors take a lot of blood flow, or things like leukemia prevent normal blood development, so the kids will look pale. And if you don't have enough blood to supply oxygen to the red blood cells to supply oxygen to your body, you're going to get tired easily, so that loss of energy. If you don't have enough platelets for normal clotting, you're going to bruise easily. Pain, very common, or one of the big problems with cancer. Both the untreated and the treatments we do can be very painful. Unexplained fever or illness can be a sign of cancer. Headaches, for intracranial pressure because there's something taking up space, a tumor. Changes in vision, so a tumor that's pushing on the optic nerve. And then rapid weight loss. Tumors take a lot of blood flow, and so it stops, it takes all the blood flow and all the nutrients, and so you get, you can interfere with normal growth. And so then treatments of cancer, unfortunately, are not easy either. When we treat cancer, we tend to kill those cells that are reproducing abnormally, the cancer cells, but we also kill off normal cells, including white blood cells, to prevent infection. So you're at risk for infection. We often give high-dose steroids, which make you immune suppressed, at risk for infection. Hemorrhage, because we often are killing off your natural reproduction or production of blood. So without enough platelets, you're at risk for hemorrhage. Without enough oxygen carrying capacity, so you're short of hemoglobin, that is anemia. Anemia makes you tired, it makes you pale, it makes you not grow well. So anemia, the cancer untreated can cause anemia, but the treatment can also cause anemia. Nausea and vomiting. Most of our drugs do a lot of GI distress. As we're killing those cancer cells, we're killing any cells that multiply quickly, which includes the GI system, a lot of the lining in the GI system. So you can get a lot of nausea and vomiting and nutritional issues from that. You can also get sores in the mouth, mucosal ulcerations, and those are very painful. They make kids not want to eat. Neurologic problems, because we can get that invasion into the central nervous system, and hemorrhagic cystitis. This is invasion into the bladder. And here's a picture of a kid with those mucosal ulcerations. We usually will have them do a swish and spit, partly for numbing it to make it feel better, and partly to prevent invasion of bacteria into the bloodstream through those open sores. So, bone marrow transplant. For many of our cancers, this is the kind of final treatment. If nothing else works, we're going to do bone marrow transplant. We can do it with a matched donor, so not their own. So what we do is collect either stem cells or bone marrow from someone, and most often they do stem cells. So they put an IV in, draw out the blood, spin off the stem cells, and then return the blood. So all the donor is giving is stem cells. And stem cells are great because they can turn into any kind of cell that the body needs. Sometimes with kids, they want to actually take bone marrow, and so they'll take that out of the pelvis. And then we take either that bone marrow or those stem cells and give it to the recipient through a slow IV infusion. We do have to make sure that the donor is compatible. Generally, a sibling is our best chance at that, but there are just random donors out there that have very similar blood types, and the closer, usually they're going to be ethnically the same ethnicity to have the most closely matched blood. Before somebody receives a bone marrow transplantation or that stem cell hematopoietic cell transplantation, we are going to basically kill off their bone marrow. So we're going to give them extensive chemo, so they are not making their own cells. We've got to give them blood in the meantime to keep them adequate in their blood supply, and then we're going to give them the recipient, or the donors, either stem cells or bone marrow, and we're hoping that will then engraft into the recipient's bone marrow and begin producing normal cells. So that's our hope with that. Be the Match Foundation. If you are not in the bone marrow registry, let me encourage you to do that. You can save a life. All it is a swab of your inside your cheek, and then they will match your tissue type. And if there's somebody who needs a bone marrow or stem cell transplant, you'll be called, and it could go anywhere in the world to help someone. And they don't do this unless it's life-threatening. So this person will die without someone coming up and being the match. Umbilical cord blood. This is a place there are lots of stem cells, and so we can retrieve those stem cells from umbilical cord blood and either save it for that child in case they ever need it, or donate it. And so that's a really great thing to do as well. And then we'll talk about some specific cancers.